हेलो आनंद जी।
जी गुड इवनिंग सर।
गुड इवनिंग। स्टार्ट नहीं हुआ है?
नहीं सर, अभी सर 5 मिनट बाकी है सर।
अच्छा अच्छा, ठीक 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 ठीक
ठीक
ठीक
ठीक।
ठीक।
Good evening, sir.
गुड इवनिंग गुड इवनिंग। ठीक है।
Sir, all right, sir.
ठीक ठीक ठीक
With
ठीक।
your blessing, we are all right.
थैंक यू थैंक यू। इट इज गोइंग वेरी नाइस। कोर्सेज आर गोइंग वेरी वेल
Yes, sir. Yes, sir.
एंड यू पीपल आर डूइंग हार्ड वर्क फॉर इट।
विकास जी आ गए क्या? डॉक्टर विकास, डॉक्टर विकास।
नहीं दिखाई दे रहा।
हाँ, नहीं नहीं, है तो कहीं।
सर सर प्रणाम सर।
हाँ, गुड इवनिंग विकास। अरे वाह वाह, क्या बात। जय हो। जय हो। गुड, वेरी गुड. We are all in time, and we are lucky to have
सर
Dr. Kamlesh Tiwari, Professor Kamlesh Tiwari, with us,
जी सर सर सर
and with the blessings of everybody like Dr. Jyotirmay Pal, President API, Dr. Girish Mathur, Dean-elect ICP, and General Secretary Dr. Agam Boda Sahab. So I'm thankful to everybody, each one of you. And of course, the whole story is led by Professor Kamlesh Tiwari. He has nurtured us like a family member. And today's topic is very, very interesting. Before I introduce you, I would like a few words of Ashirvachan from Dr. Kamlesh Tiwari, sir. Sir.
Thank you, Dr. Ajay. I think this course is going very nice, and it is due to you people, the master teachers. You people are working very hard and trying to search the good people of the country to teach the students. I'm thankful to you all, and I like that Dr. Vikas, to whom I have talked already for this course, will start his course today. Thank you. Thank you very much.
Thank you, sir. I am thankful to all the erudite uh, people like Dr. Jyotirmay Pal and others who have led the journey. Dr. Tiwari has been instrumental in starting this project, and with his help, we are almost reaching 50% marks.
That's right.
Yeah. So uh, let me introduce our today's guest speaker and master teacher, Dr. Vikas. Vikas Singh is a brilliant son of soil from Bihar. and I have the occasion of working with him many a times. Right from Paris, we have studied together, we have grown together, and we have published together, and we have presented together. You know, uh, Vikas is a product of prestigious Patna Medical College. After he did his DM from Lucknow, and uh, he has worked in Paras Hospital in the capacity of consultant cardiologist. Now he has his own hospital, Daksh Cardiac Center, as well as he is working for Mediversal uh, Hospital, which is one of the prestigious hospitals of the city. And Dr. Tiwari and me, we both have great feeling for Dr. Vikas Singh, and he has done so many. He has so many accolades in his kitty, and he has so many fellowship, so many publications, and he has been in the editorial board of so many prestigious journals. So over to you, Dr. Vikas. Your job is to teach our students today, and on the issue of acute coronary syndrome, the clinical aspect. So over to you, Dr. Vikas.
Thank you so much for the introduction, sir. You are always very generous with your words. And before I begin, yes, pranam to our Dean ICP, Dr. Kamlesh Tiwari, sir. He has been very instrumental in starting this project of his. My topic for this evening has been planned for by sir only. He thought we should be talking about a subject which is very common, which is something, a topic of interest for each one of us who is practicing medicine, and in fact, who is learning medicine for that matter. So, nothing like acute coronary syndrome. And I would be discussing in brief what a physician should know. So, acute coronary syndrome in itself is a huge topic, and I would be making it short for you, but I'll be making sure that we get into touch with every aspect of acute coronary syndrome that one should be knowing. So, with that background, let me move. We know chest pain is one of the commonest causes for emergency room visits. If you look at the worldwide data, the commonest cause probably why someone presents to the emergency would be chest pain. Now, the causes of chest pain can be something benign. A pain of gastritis can be mimicking acute coronary syndrome many a times. And the causes can be life-threatening, like acute coronary syndrome as well. So it is a whole spectrum of causes of chest pain that someone presents to the emergency with. Now, coronary artery disease is the leading cause of morbidity and mortality worldwide. So I would be taking you through a case discussion sort of a thing that would make things little interactive also and a little bit easier for us to understand. So my patient this evening is a 50-year-old male. He is hypertensive on irregular treatment. He's an occasional smoker. He has a history of mild epigastric discomfort on effort for last 2 weeks and lower retrosternal and epigastric discomfort at rest for 6 hours. So let us analyze this patient. Now, he's a 50-year-old male. He's having certain risk factors for coronary artery disease. He's having hypertension. He's a smoker. And now he's having a pain for last 2 weeks, which he has been thinking that probably it's not related to his heart. And he tried all sorts of self-medications before presenting. Now, that is the usual scenario for every patient, not only in Bihar. I'm sure everyone who presents to us anywhere in the country would try many things on his own before presenting to the emergency. Someone from the relative would advise, someone from Google, some information from Google or YouTube that would also help them in deciding for any medications before presenting to the emergency. So the first thing first, whenever you are dealing with a patient, listen to the patient. And we have always been taught about by our teachers the importance of history taking. And after learning cardiology, I have realized that nothing more important than history taking when you are dealing with any patient for that matter. And if you just give some time listening to the problems of your patient, they will tell you exactly what is wrong. Otherwise, just relying on ECG, echo, troponins can all make you miss the diagnosis. Now, I'm sure you all are aware of the term unstable angina. Now, an unstable angina patient can have an absolutely normal ECG, can have a normal troponin level, can have a normal echo, but still, this patient is at a very high risk of cardiovascular death because of the underlying condition, which is which may be a very critical blockage. So, what do we want to hear or get from the history that will make us conclude that this patient may be having a cardiac pain? So, the character of the pain or the location of the pain and how it is precipitating and how it is relieving, everything about the pain that will help you decide what sort of a pain it is. So, someone who is having a substernal chest discomfort, which is coming with exertion or emotional stress and which is getting relieved with rest or nitroglycerin. If all these three things are present, rest assured this is a cardiac pain. No matter what your ECG is saying, no matter what your echo is saying, you are sure this is a cardiac pain. Now, atypical angina is when two of these three criteria are present, and non-cardiac chest pain is when only one of these is present. Now, having said that, we also need to know that there are gender-specific differences in presentation. So female patients many a times have a totally different presentation of acute coronary syndrome, what we commonly say atypical presentation. So they may present with shortness of breath only, nausea, vomiting, unexplained anxiety, palpitations. So all of these are possible modes of presentation in female as well as in elderly. So you need to be very careful in judging the symptoms when you are dealing with women as well as elderly patients. Now, a very common confusion is it heart attack or heartburn? And your patients would keep on repeating, they'll keep on enforcing their ideas into your mind. He said, this is just gas. I'm not having anything. I'm just having gas. So don't just get intimidated by what your patient is saying. There is a very thin line between heart attack and heartburn. And many a times, in spite of listening very carefully to your patient, you may not be sure what it is. And then your investigations will help you in further deciding the course of action. So everything has a role, but don't skip the history part. It is very important when you are dealing with your cardiac patient. Similarly, there are very close mimickers of acute coronary syndrome. Someone who is having pain in your left side of the chest, if you just give some time listening to them or just examine your patient in a proper way, you can find that he's having eruptions of herpes zoster, and what you were thinking of in terms of acute coronary syndrome is actually eruptions of herpes zoster. Someone can be having inflammation of a costochondral joint, what we call teeth syndrome. Then even a pneumonia can mimic acute coronary syndrome because the patients can complain of that pleuritic pain, which is at times very sharp, very excruciating, and that may mimic acute coronary syndrome. For that matter, even inflamed pericardium or pain of pericarditis can also mimic acute coronary syndrome. So you can judge the differentials to a large extent on the basis of a good history as well as a proper examination. Now let's come back to our patient. We had discussed about our patient who has tried all sorts of self-medications before presenting to us, and he is having lower retrosternal and epigastric discomfort at rest for 6 hours. Now, let me ask all of you, which investigation would you like to do in your patient? I'm not sure if you can reply here, but you can certainly reply in your chat boxes. So what do you think should be done for this patient? Will you be going for a chest X-ray? Will you be ordering a troponin T test or an ECG or a TMT? So is there any way we can have a, let me go ahead. So all of these investigations which we are discussing here, they all have a role to play in investigating your chest pain patient. But the first test that you would like to have is undoubtedly an ECG. And an ECG because of many reasons. It is a very easy test to do. It hardly takes a minute, but that will give you a whole plethora of information that will help you to differentiate whether that chest pain can be fatal or is it something else. So we ordered a chest, suppose we ordered an ECG for our patient, and this is the ECG. That is there any doubt what we're dealing with? Now you can see a very well ST elevation MI. You can appreciate ST elevation in leads 2, 3 AVF as well as ST depression in 1 and AVL. In fact, depression is also evident in leads V1 and V2 and V3. So we are dealing with an acute inferior wall myocardial infarction. So this is the beauty of an ECG. In fact, guidelines emphasize on getting an ECG as quickly as possible. Ideally, no more than 10 minutes should be wasted whenever a patient with chest pain presents to you in the emergency. Now, at the same time, this is a word of caution for all of you. Do not be fooled if the ECG is normal. Suppose the same patient, if the ECG was different, if the ECG looked overtly normal, you should not be saying that this is a non-cardiac chest pain or this patient is not having any cardiac symptom. That is a pit hole for you, and because in 40% of cases of acute MI, ECG is inconclusive. So what should one be doing if suppose you encounter an ECG which does not reveal much? Suppose this was the ECG with the same patient. Now, for someone who is an expert in analyzing ECG, can make out that there are certain changes in the inferior leads which is just evolving. You can see slight elevation in the inferior leads, but this is non-conclusive, particularly when you compare this ECG with the previous ECG, where you could very well appreciate the ST elevation in leads 2, 3 AVF. So the guidelines say that whenever you deal or come across a patient with an ECG like this, where a clinical picture is suggestive of acute coronary syndrome, don't let these patients go. Keep them under observation. Go for serial ECGs. Serial ECGs means every 10-15 minutes you go on repeating ECG. So the same patient, after 15 minutes, you can get an ECG of evolved inferior wall MI. So this is one rule that you should follow. If clinical history suggests acute coronary syndrome, do not dismiss patients as non-cardiac just because the ECG looks normal. Now, this is the guideline that I was talking about. A 12-lead ECG recording and interpretation is indicated as soon as possible at the point of first medical contact with a maximum target delay of 10 minutes. That is what we should be practicing. That is what we should be targeting for all our patients. Now, what is an ST elevation? Suppose someone would be keen to know, sir, how much is should be the ST elevation that is significant for any particular case. So the guidelines here also suggest the diagnostic ST elevation in the absence of LV hypertrophy or LVBB, that is defined by the ECC, ESC, ACCF, and AHA for the universal definition of MI as new ST elevation at the J point in at least 2 contiguous leads of 2 mm in men or 1.5 mm in women in leads V2 to V3 and or of 1 mm in other contiguous chest leads or the limb lead. So for V2, V3, the criteria is 2 mm in men and 1.5 mm in women. And for all other leads, it should be 1 mm or more in both the sexes. And just to give you an idea about localization of MI, so 2, 3, and AVF are the inferior leads, which means the blockages are either of right coronary artery or left circumflex artery. Lead 1 and lead AVL guide you towards the lateral aspect. So they would provide you information about the lateral aspect of the heart. And most commonly, you'll have a lesion of left circumflex or diagonal of LAD when you have an elevation in lateral leads. V1 to V4 would be anteroseptal. So this is a rough idea regarding localization of ST elevation MI. Now, when we talk about acute coronary syndrome, it's not always possible that you are getting ST elevation MI only. You can have the whole spectrum of ACS. So the patients may be having minimal symptoms right then to the other extreme of having a cardiac arrest right at the presentation. This could be the difference in presentation of your patients. Now, the ECG finding can be absolutely normal, yet the patient can be having an acute coronary syndrome. You can get ST segment depression, you can get ST segment elevation, and even the first presentation can be with malignant arrhythmias. So you need to be aware of all these things. Now, a common concept nowadays, which is evolving and which is, I don't think that should be the way out. It's good that we know that acute coronary syndrome, you should be having a cath lab around. But if just in case you are working in a setup where you don't have a cath lab, all is not lost. So you should be remembering you have a whole armory of wonderful medications which you can use for your patient and still help your patient, even if you're not having a cath lab around. If you're having a cath lab, nothing good than that, nothing better than that. But even if you're not having, don't be disheartened. Now, ground, coming to the diagnostic blood markers. Now, blood markers, they are rapidly gaining a lot of popularity. It's very common to advise troponins and CKMBs and myoglobins to any patient who is coming to us with chest pain. Now, it's important to understand that each of these biomarkers, they have their own patterns of elevation, sustenance, and then downfall. So you need to be aware troponins. It's not a good idea to order a troponin T for a patient who had a chest pain a month back, because you should be knowing that in 14 days of time, even the troponins will return back to normal. So that understanding has to be developed. The earliest biomarkers which rise is the myeloperoxidase, and then troponins are the most commonly biomarkers that are used. Now, if you come across a patient who has an ECG which clearly shows ST elevation MI, like the first ECG that we discussed in our patient, you should not be wasting time waiting for the troponin T report. Now, that is another bad thing that you often come across. Patient has an ST elevation MI, he has been ordered for a troponin test, and everything is on a standby. Why? Because you are waiting for the troponin test to report result to come to you. Within 6 hours window period, even the troponins may be negative. And that troponin level does not guide you to any treatment which you should already be starting just on the basis of your ECG finding. So this is one take home that you should be understanding, that these troponins are to be used when you have a confusion in order to guide treatment. But otherwise, where ECG changes are sufficient to guide you towards the diagnosis, you should not be wasting your time. Now, coming back to our patient, his BP is 140 by 80 millimeters of mercury, pulse is 90 beats per minute, chest is clear, CVS, no S3 and no murmur. He is definitely anxious, and a saturation of 98% on room air. So the other question that I would like to ask all of you here is, will you start this patient on oxygen based on the vitals that we just discussed? Saturation of 98% on room air. Why I'm putting forward this question is, another common tendency, the moment you know this is a patient of acute coronary syndrome or MI or ACS, the first thing that most of us or many of us would do is put in on oxygen mask. Now, this is a bad idea. You should certainly not be starting this patient on oxygen. The guidelines very clearly say that oxygen is indicated in patients with hypoxemia, which is defined as saturation less than 90% or partial pressure of oxygen less than 60 millimeters of mercury. And why? What is the harm if you unnecessarily give oxygen to these patients? So oxygen has a vasoconstrictive effect, and you want vasodilators here. You want to dilate the blood vessels which is already blocked. So routine oxygen is not recommended in patients with saturation more than or equal to 90%. That is given a class 3 recommendation by European Society of Cardiology. So be very careful when to use oxygen in your patients. Now, the guidelines, the 2025 ACC guidelines and 2023 ESC guidelines, they have further clarified many of the issues surrounding acute coronary syndrome and the medications part. First, let's understand the management of acute myocardial infarction, how that has evolved. And you'll find it very interesting, in fact, if you understand what changes have occurred that has brought the mortality down. So you can divide it into 3 eras. One is the pre-CCU era, where you had absolutely nothing, no critical care facilities to take care of your patient. The mortality of acute myocardial infarction at that time was close to 30%. Then came the CCU era. Now, what changed with CCU era? You started giving beta blockers. you started using defibrillation, you had a better monitoring of the hemodynamics. So by doing all this, you were able to prevent many sudden cardiac death and the arrhythmias largely. So the mortality dropped from 30% to 15% in these patients. And then came the reperfusion era, where we realized that we need to open up the blocked arteries so that the heart is preserved also, so that the chances of arrhythmias is less, and that we attained using thrombolysis and angioplasty as well as stenting, and the mortality rate again dropped from 15 to close to 6.5%. So this is how medical therapy has evolved. This is how mortality rates have gone down from 30% to 6.5%. Now, coming to the medications that we should be giving in this patient of ours who has now, we are shown, has now suffered a acute inferior myocardial infarction, aspirin. So don't underestimate this drug, I would say. The worst part with aspirin is it is one of the most misused antiplatelets. So you'll come across many patients who have been taking aspirin without any indication for years and years. And then you will also come across patients who should be receiving aspirin, but they are not receiving aspirin for no reason. So what aspirin does is this is an irreversible inhibitor of platelet aggregation. It stabilizes the plaque and arrests the thrombus formation occurring inside the coronary arteries. You need to be careful when you are using this drug with active ulcers, hypersensitivity, or bleeding disorders. In acute myocardial infarction, aspirin reduces the risk of death by 20 to 25%. And that is the reason why you prescribe aspirin as the first thing to do when you come across the ACS patients. In unstable angina, aspirin reduces the risk of fatal or non-fatal MI by 71% during the acute phase. Now, what should be the dose? The dose should be 160 to 325 milligram, but the more important part is it should be chewed and swallowed. The commonly used medication, the ecosprin, they are mostly covered, they are entery coated. You want your aspirin to be starting its action very quickly, and that is why the idea is to just chew it, swallow it, so that it starts working all of a sudden or as soon as possible. Now, apart from aspirin, we have other antiplatelets also, because the moment acute coronary syndrome is diagnosed, you have to use two antiplatelets. One is aspirin, the other, in the initial part, it was ticlodipine, then clopidogrel, and over the late part, it is prasugrel and ticagrelor, which have emerged as the newer antiplatelets. So this is how has been the journey of oral antiplatelets. Now, when to use this molecule? This is from the recent 2025 guidelines. ACS initial selection of oral P2Y12 inhibitor for in a PCI setting where you are planning for an angioplasty procedure. No matter it is a non-ST elevation MI or ST elevation MI, you have to use aspirin, and in addition, either of ticagrelor or prasugrel as the class 1 indication. Clopidogrel is used only when these two molecules, ticagrelor or prasugrel, is not available, when it cannot be tolerated or is contraindicated for any reason. So clopidogrel assumes a backseat, either of ticagrelor or prasugrel, particularly in your intervention patients. Now, in your CABG patients, it is important to know that you can continue with aspirin during CABG, because many a times we have a tendency to stop every antiplatelet while the patient is being planned for bypass surgery. So the other P2Y12 inhibitor is to be started post-operatively when you find it safe, but otherwise continue with aspirin. When your patient is planned for a medical management only, the best combination at this point of time would be aspirin with ticagrelor. And again, clopidogrel is to be used only when ticagrelor is not available or is not tolerated for that matter for any reason. If you have fibrinolized your patient, if you have thrombolized your patient of STEMI, aspirin plus clopidogrel here would be a better choice. An alternate P2Y12 inhibitor can be considered if these patients are later taken up for angioplasty. So to simplify things for you, high-risk patients, think prasugrel or ticagrelor. Prasugrel has some drawbacks. It has to be used only in patients who are less than 65 years of age and more than 60 kgs of weight, because otherwise it increases the risk of bleeding and spoils all the benefits that you are planning to give to your patient. The fastest acting molecule is ticagrelor, particularly if you can crush it and give it to your patient. It has a very quick onset and early offset as well. Now, once you have given aspirin as well as other P2Y12 inhibitor, the next thing that you should be doing is giving high dose of statin. Now, the benefit of statin in secondary prevention has been unequivocally demonstrated. It is recommended in all patients with acute MI, irrespective of cholesterol concentration at presentation. So you should not be bothered about what the cholesterol levels of your patient is. The moment you get an ECG or the moment you diagnose your patient as acute coronary syndrome, go for high dose statin therapy. Now, the intensity of statin therapy should be increased in those receiving a low or moderate intensity statin treatment at presentation, unless they have a history of intolerance. So suppose someone is receiving atorvastatin 20 milligram. Now, if he suffers an acute coronary syndrome, you should increase this 20 milligram to 40 to 80 milligrams. You should not be stopping at 20 milligram. That is the whole idea conveyed here. So in your ACS patients, you should be starting high dose statin to all your patients. And if the goal is not achieved with only statin, the newer guidelines have given a class 1 recommendation to add a non-statin LDL lowering therapy if your LDL cholesterol is more than 70 despite maximal tolerated statin treatment. So this is another thing to remember, that if statins is not able to take care of the targets, go for additional LDL lowering therapy, which can be ezetimibe or monoclonal antibody, the CS9 that we talk about, evolocumab and alirocumab. It can be inclisiran, the newest additions, the inhibitor of PCSK9 synthesis, or even the bempedoic acid, that can all take care of LDL lowering if statins are not sufficient. Now, the next question is, what should be done now? Our patient has received aspirin, he has received clopidogrel, he has received atorvastatin. What next? Are we missing here something? So anticoagulation. Anticoagulation is equally important when you are dealing with acute coronary syndrome. Anticoagulation is recommended in patients treated with lytics until revascularization or for the duration of hospital stay up to 8 days. The anticoagulation can be enoxaparin or unfractionated heparin or even fondaparinux. And this is not only for patients just who has been fibrinolyzed. This is true for all patients of acute coronary syndrome. Most of our patients would also be having some degree of renal compromise. The patients who come to us with acute coronary syndrome generally have comorbidities in terms of hypertension or diabetes or some degree of renal impairment. So this slide I have deliberately kept here to emphasize that whatever may be the kidney compromise, up to stage 4 CKD, there is no dose adjustment for aspirin, clopidogrel, ticagrelor, or prasugrel. So you can very well continue with the doses that you know for standard patients, even in up to stage 4 CKD. Only with enoxaparin, you bring down the doses from 1 milligram per kg twice a day to 1 milligram per kg subcutaneous once a day. Now, stage 5 CKD is totally different subset, less than 15 milliliter EGFR, because then you don't have much information available regarding what should be done. But that would be a very small subset of patients. For a large subset of patients, we know there is no change in the antithrombotic doses. Coming to the thrombus formation in MI, we know fibrin, platelets, RBCs, all of these take part in thrombus formation. The white thrombus, the non-totally occlusive thrombus, which is commonly seen in non-ST elevation MI, is largely comprised of platelets, whereas red coagulant thrombus, which is seen in STEMI, also has a big contribution from the RBCs. And that is why the difference in the management of non-ST versus ST elevation MI. Now, of late, primary PCI has gained a lot of attention, and rightly so, because the kind of advantage it gives to your ST elevation MI patients in particular is just amazing. You cannot match just primary PTCA across the spectrum of ST elevation MI patients, no matter where they are presenting in terms of their duration. But the problem is it always possible? Particularly when you are dealing with a country like India, where you have so many logistic problems available, so many problems from the patient part, patients mostly presenting to you after 24, 48 hours. So there are so many barriers why primary PCI may not always be the best strategy for your patients. And for them, we talk about the pharmaco-invasive approach. So for ST elevation MI, the focus is only not to waste any time because time is muscle. So you want to offer the best treatment that you can give to your patients at that moment of time. And that is the reason why you thrombolize these patients if the facilities are not near. And then you shift these patients to a center where primary angioplasty can be done. So this is a combination, the combining good from both the strategies. Thrombolizing so that you can save time, and then going ahead with primary angioplasty. We call it lies today, stent tomorrow. So again, one important area that I would be keen to discuss is invasive management is not only for ST elevation MI patients. One common mistake that we make often is we take ST elevation MI very seriously. Okay, this is inferior wall, this is anterior wall MI. But our tendency is non-ST elevation MI somehow does not deserve that attention that it should be deserving because it carries the same mortality, particularly the very high risk subsets. So STEMI patients, primary PCI or fibrinolysis, for very high risk non-ST elevation MI patients, immediate angiography plus minus PCI. So non-ST elevation MI, they do not receive fibrinolysis. That is the only difference. Otherwise, PCI is equally applicable for both these spectrum of acute coronary syndrome. High risk non-ST elevation MI should be receiving early or less than 24 hours angiography should be considered here also. So we should be risk stratifying our patients. Not all non-STEMI patients should be dealt with in the same way. You have a scoring system like the GRACE risk score or the TIMI risk score, which you can utilize based on many criteria like the age, systolic blood pressure, heart rate, ST segment deviation, Skilip class. So all of these using together can give you an idea regarding the possible mortality risk for these patients in terms of the risk in hospital risk or at the time of discharge risk, and then you can classify or plan what you need to do for these patients. So coming back to our patient, the nearest PCI capable center is around 120 kilometers, suppose, and it would take around 2.5 hours to reach there. So it would not be a good idea to plan a shift for our patients when we know it's going to take almost 2.5 hours. The guidelines are very strict regarding the delays because the entire system works on how to cut time so that your patient can have the benefit of revascularization. It does not make any sense to transfer your patients taking 10 hours time to go for an angioplasty when you know the entire myocardium is dead now and there is hardly any benefit that your patient is going to get. So the total ischemic time should be minimized, and that is the reason why we talk about the pharmaco-invasive approach. Primary PCI strategy means within 90 minutes, wire crossing should be done. Fibrinolysis strategy means within 10 minutes, the patient should be receiving the thrombolysis. And this is the maximum, the system time targets that has been described in the ESC guidelines. Maximum time from first medical contact to ECG and diagnosis, we discussed in the beginning also, only 10 minutes. The maximum time delay from STEMI diagnosis to primary PCI should not be more than 120 minutes. And maximum time from STEMI diagnosis to wire crossing in patients presenting at a primary PCI center, less than 1 hour. So this is how things have to be evolved. It may not always be possible to match those timelines, but our target should be to meet them in most of the patients that come to us. And this is what the guidelines say. If the patient is presenting within 3 hours of STEMI, primary PCI or fibrinolysis, that both of them have a class 1A recommendation, up to 12 hours, the same recommendations, class 1A for both fibrinolysis or primary PCI. And primary PCI definitely has to be given an upper hand if that can be done. Between 2 hours and 48 hours, primary PCI should be done as a class 1 recommendation if the patient is having symptoms or if he is hemodynamically unstable or you come across arrhythmias. Primary PCI can be done up to 48 hours even in asymptomatic stable patients, and that is a class 2A recommendation. So that is another thing that you should be knowing, that up to 48 hours, if your patient has suffered a heart attack, he should be undergoing a primary PCI strategy if that can be made. So after 48 hours, routine angioplasty is not recommended if your patient is not having any symptoms. Now, a word about thrombolytics. Now, thrombolytics have also evolved from good to better, like any other thing uh, for that matter. First generation thrombolytics as streptokinase, urokinase. Second generation is TPA or alteplase infusion. Third generation, the retiplase and the tenecteplase. That is now most popular because of the ease of administration. They are given as bolus doses compared to streptokinase and alteplase, which required an infusion to give. More so, these newer generation stents, newer generation thrombolytics, they are more thrombin specific. So the chances of adverse effects is low. So which fibrinolytic? So that is a general question for all of you. But if funds is not an issue, if monetary restrictions are not there, definitely you should be choosing between retiplase and tenecteplase. But before going ahead with fibrinolytic therapy, a word of caution, you should be ruling out the contraindications for fibrinolytic. That is very important because this unnecessarily not only complicate the case if you're not ruling out the contraindications, but that can also lead you into medical legal complications. So there are certain absolute contraindications to fibrinolytic therapy. Previous intracranial hemorrhage or stroke of unknown origin at any time. That is an absolute no for thrombolysis. Ischemic stroke in the preceding 6 months. CNS damage or neoplasms or arteriovenous malformations. Recent trauma or surgery or head injury within the preceding month. Gastrointestinal bleeding within the past month. Known bleeding disorders excluding menses, aortic dissection, and non-compressible punctures in the past 24 hours, like a liver biopsy or a lumbar puncture. So these are absolute contraindications. So for that matter, our patient received a double bolus retiplase, and after some time, 45 minutes later, pain is largely settled. ECG ST segment is now settled. But suddenly, you notice some changes on the monitor. So what is happening here? You are getting all good signals. You are getting, the patient is saying, I'm feeling better. ECG shows settlement. But then this is occurring. You come across the ECG, you take out the ECG, you find this is happening. So what is this? What is happening here? What does the ECG show? Is it normal sinus rhythm? Is it ventricular tachycardia? Is it atrial fibrillation? Or is it AIVR? So we cardiologists are not very happy to see arrhythmias coming to us. But this is one arrhythmia which should make you happy, which makes anyone happy once they are dealing with an acute coronary syndrome. Why? Because this shows that revascularization has occurred. The blocked artery has opened up, and this is a transient arrhythmia, which is accelerated idioventricular rhythm. So this is one marker of successful thrombolysis. Your thrombolysis has worked, and that should make you comfortable. Most of the times, you don't need to do anything. Just wait, just keep an eye on the vitals of your patient, and that should be it. In some time, it gets back to normal. Now, another question for you. Now, our patient was lucky. He received thrombolytics. His pain has now subsided. ECG has settled. AIVR is occurring on the ECG. So all good signs here. But not everyone is going to be so lucky. Now, what if he had continued to have pain and the ECG was not settled? Now, this is also a possibility. So do you repeat retiplase? Do you give another thrombolytic? Okay, I'll try tenecteplase this time. Or do you shift to a PCI capable center? Or do you give an injection of diclofenac or Dilona that we commonly know? I'm sure you're not going to repeat retiplase because that doses should not be repeated. That is meant for a single bolus dose only. Giving another thrombolytic will not make any sense. What one thrombolysis has not done, adding another thrombolytic agent is only going to increase the bleeding risk. So that is an absurd option again. So the thing to do here is to shift to a PCI capable center. If you have tried thrombolizing, if your patient has not responded to that thrombolysis, the only next step to do is to shift to a PCI capable center, and that artery needs to be opened up. So our patient, He's comfortable now. The pulse rate is 80, BP is 140/80. Meanwhile, we also got an echo done. Echo shows a regional wall motion abnormality with an ejection fraction of 40%, mild mitral regurgitation. Now, he was started on tablet metoprolol tartrate, 25 half tablet BD, and ramipril, 2.5 milligrams, one tablet OD. So, what do these medications do? Why we have started him on beta blockers, metoprolol? The guidelines say that oral beta blockers should be initiated in the first 24 hours in patients with ST elevation MI who do not have any of the following signs of heart failure, evidence of low output state, increased risk for cardiogenic shock, or other contraindications to use of oral beta blockers. So you need to be careful. You need to be choosing your patients regarding when to initiate beta blockers. If the BP is on the lower side, if your patient is in heart failure, definitely do not use beta blockers here. Do not be in a haste to use beta blockers. But otherwise, if your patient is otherwise stable, like our patient has been behaving, definitely institute beta blocker as soon as possible, ideally within 24 hours. So this beta blocker gives 14% reduction in mortality risk at 7 days and 23% long-term mortality risk reduction in ST elevation MI. So you want to give your patients the benefits from every molecule that you can possibly can. The second molecule is renin-angiotensin-aldosterone system inhibitor. We had used ramipril here. So why ramipril? Because again, an ACE inhibitor should be administered within the first 24 hours to all patients with STEMI with anterior location, heart failure, or EF less than or equal to 40% unless contraindicated. So it takes care of the remodeling part, the whole cascade of mediation, the unfavorable things which are occurring in the ACS patients. Blocking this renin-angiotensin-aldosterone system would help you there. And ARB should be given to all patients of STEMI who have indications but are intolerant to AC inhibitors. And similarly, a mineralocorticoid receptor antagonist should be given to these patients. Now, our patient was then transferred to the nearest PCI capable center. Another very important take home for all of you would be your work does not end once you have thrombolized your patient, once your patient looks overtly okay. You should transfer all these patients for an angiography to the nearest PCI capable center. So that was done with our patient as well. He was transferred to the nearest PCI capable center. Angiography was done by the radial route. He only had a 30 to 50% lesion in mid RCA. That means our thrombolytics had done their job. The artery is now recanalized. Drugs are optimized. Eplerenone 25 milligram was added after checking potassium and creatinine, and things are all good for the patient now. So what I was just discussing, indications of coronary angiography in patients who were managed with fibrinolytic therapy. So look at the bottom part first. Stable patients with after successful fibrinolysis before discharge and ideally between 3 and 24 hours. That is a class 2A recommendation. Now, if it is a failed reperfusion or reocclusion, you have to transfer these patients for an angiography. That is again class 2. Spontaneous or easily provoked myocardial ischemia. So suppose your patient has been thrombolized. He is okay when at rest, but when he goes to the toilet, he starts having chest pain. So this is easily provoked myocardial ischemia. He should again be referred for an angiography. Then intermediate or high risk findings or pre-discharge non-invasive ischemia testing. These are all class 1A recommendations. Suppose someone is in cardiogenic shock or acute severe heart failure that develops after initial presentation, again, they should be referred for an angiography. Now, there are other aspects apart from the invasive management part, apart from the medication part. You should also be touching the behavioral aspect after ST segment myocardial infarction. Identify the smokers. They keep repeating that this is bad for you and you should be giving up smoking. That will go a long way in managing your STEMI patients in a better way. The patients are very receptive when they have undergone or any procedure or when they are in the hospital part. Once they are discharged, they start taking things not that seriously. Participation in a cardiac rehabilitation program again is recommended as a class 1 recommendation strategy by the guidelines. So to summarize for you, dealing with the ACS journey, that is not a matter of only one specialty or only one thing to do. It involves a whole patient-centered approach to the ACS journey. You should consider all risk factors. You should establish a medical history, consider psychosocial factors also, individualize care and triage, perform a person-centered clinical assessment. So everything has to go hand on hand. And you, as a caregiver, we should be trying to address all of these strategies right at the hospital admission part, as well as when we are sending them back home. Now, this last slide is not for the patient part, but for all my colleagues here who are listening to me, the medico-legal aspect. So acute coronary syndrome is one area which will give you probably the maximum medical legal cases as well, because everything happens so dramatically. Someone who was absolutely okay half an hour back would be getting sick in no time, would be presenting to you in spite of doing everything. Suppose the patient loses his life, it becomes very difficult for everyone around to digest what's happening, and they will put the blame all to you, that my patient was well half an hour back or 1 hour back, and you haven't done your work properly. That is why my patient is no more. So medical legal aspects, that is for your safety. Communication is the key. Communicate everything to your patients. Then documentation, that is very important. Document everything on records, because in the court of law, nothing stands except what is documented in your papers. And then communication of documentation. You communicate that I am documenting everything what I'm telling to you. That will keep them in the backseat. They'll know that everything is there in the paper. And then documentation of communication. Also write that we have discussed everything, we have explained the prognosis, we have done everything possible, and that will all these four things will help or will go a long back in protecting yourself as well. So with that, thank you so much. Thank you so much for the patient hearing, and I would be very happy to take up any questions if there are. Thank you.
Thank you very much, Dr. Vikas. Excellent. So it was so simplified that even the basic people will also learn how to manage the acute coronary syndrome. Any question from anybody? There is a question from Dr. Neha Kumari. How to deal with a patient having intracerebral hemorrhage and MI, both that in acute cardiocerebral infarction? That's a very good question. Over to you, Dr. Vikas.
So that is probably the worst case scenario to occur. I mean, you pray to God more often than not, because those two conditions demand absolutely opposite things. When someone has developed a cerebral hemorrhage, you want the bleeding to stop. But at the simultaneously, if someone is having a myocardial infarction, you want blood thinners and all sorts of blood thinners, in fact, to keep things going. So that is the worst possible scenario. You cannot thrombolize these patients. You cannot use antiplatelets in these patients. If you have a PCI capable center, you can definitely go for an invasive strategy here. You can use other medications that are available to you, like high doses statins, like beta blockers, like AC inhibitors. But until and unless the top compartment, the brain, is stabilized, there is no other way out. And in fact, even putting in a stent is not going to be an easy task, because if you have opened the artery, put in the stent, but when you're not using antiplatelets, there is every likelihood that the opened arteries will again reocclude. So that is unfortunately the worst combination to occur. But the best part is that is very uncommon to occur. So you don't come up with that combination very common. Yes, a combination of ischemic infarct as well as a combination of MI occurring side by side is very common. And there, the good part is you can go ahead with all the modalities that we have discussed right now.
Another question from Dr. Yasmin. Very good question. What about checking all the peripheral pulses in patient with chest pain? What is the importance? He says, how often we practice, this practice is done. So chest pain, checking pulses and all. Yes.
Now, that is a very good idea to do, because aortic dissection, that you would be able to pick up aortic dissection that is one thing which in all likelihood would be missed. And if you are able to find out aortic dissection just by looking at the pulses, nothing better than that.
Yeah.
You have been able to save one life. You have been able to not thrombolize these patients, which should not be done, in fact. And that is a great thing to do. But the worst part is now you are so busy, you're not even taking a good history. Forget about examining both the pulses at the same time. So that is what the whole idea of this discussion this evening was, that we should be not be jumping to the diagnosis and straight away ordering a troponins and an echocardiography or an angiography right away. The what we have been taught from our school life, that should not be missed. A good history, a physical examination, even a focused and a very quick physical examination, that does not take much of your time. So that is a good thing to do. That is a very good take home, in fact.
Yeah. Now there are some other questions also very interesting. If somebody is allergic to aspirin, then what is the choice? And what is the loading dose of clopidogrel? I think Dr. Vikas, they agree that, we can use 300 milligram, at least 300 milligram of clopidogrel. And
Absolutely.
yeah, and the other question is AIVR after successful thrombolysis. Why there is AIVR? I mean, this is something which is, so somebody commented that is ECG was of ventricular VT. That was probably wrong. I don't know who answered it. But AIVR, Dr. Vikas, somebody asked why this happens.
So that is because the whole milieu and everything, the entire blood flow has been stopped for some time. So all sorts of mediators are going on. The changes at the cellular levels are going on. And then when you open up the arteries, I'm not sure about the exact electrolyte that plays a part there, but because of influx of those electrolytes, this is a transient phenomenon that occurs.
How to manage refractory cardiogenic shock in acute MI? There's another
Then
question.
you have refractory cardiogenic shock will require a cath lab center. You will need to open up the arteries. You will need an IABP or LV assist devices to take care of the body function at that time, the cardiac function at that time. So these are all difficult case scenarios. Refractory cardiogenic shock cannot be managed medically. You have to go for a good hemodynamic support. You have to have a cath lab team that is ready. You got in for opening up of the complete revascularization of these patients. And in spite of doing that, these patients they have a very high mortality risk.
Dr. Neha has asked a question, how to manage MI in patient with chest pain with hypotension? Can we use nitrate? Obviously not. If somebody is having hypotension, nitrate will worsen hypotension. So any comment, Dr. Vikas? Hypotension with acute MI.
Again, this is one subset which would benefit the most. See, in hypertension, even thrombolytics would not work that better. So you need to have all these difficult case scenarios. You have only one solution, and that is having a cath lab, going ahead with an angiography, opening up of the arteries. But till the time you're able to do so, you'll need to go for vasopressor support or stabilize your patients till the time you are transferring them to the nearest PCI capable center.
Yeah. So PCI, good PCI capable center with 24 hours backup. That is very important. If somebody comes in the midnight, you say that it cannot be done. This is not the answer. The PCI capable center should have a cath lab working round the clock and a qualified cardiologist who is capable of doing primary angioplasty should be there. And the team has to be very, very strong. Anesthesiologist, a good technician, all the hardware is available. IABP should be there at night. So all these things. So as Dr. Vikas was telling, that all the difficulties will require presence of a very good team with cath lab. Any other question? So I think this is a very good discussion. Any other questions somebody wants to put? And very good interaction as well. All our students and our junior colleagues have done exceedingly well, I would say. So a very good message Dr. Vikas has given about antiplatelet, antithrombotic, statin, high dose, and this arrhythmia, AIVR, which is very interesting. It looks so horrifying on the monitor. It will frighten you. But this is a manifestation of opening up the artery. You open up the artery. This is your success story, not to be sad. If you see AIVR, you don't have to be sad. And it doesn't require any interference also. But that's very important. Dr. Vikas has clearly said that the arrhythmia of reperfusion arrhythmia do not require any treatment. You have to careful watch. So that's all. Any other question from anybody? So very good slide he has shown. I think you can share all these slides to. We will definitely request Dr. Vikas to write a kind of summary or synopsis on this issue so that in the end of it, we can have a compendium which can be released for you all.
Really, sir.
Tiwari, are you there, sir? Anybody who wants to make a comment? Anybody who wants to make a comment is most welcome. If not, then thank you very much, Dr. Vikas, for your deliberation. And
Thank you,
we
sir.
appreciate your involvement and a kind of dedication, and you have prepared it very well. So thank you very much. And thank you all our colleague, junior colleague, and all the students. Thank you very much. So wait till the next Friday when we expect another good bombshell to come. Let's see who is coming. Thank you very much. Good night.
Good night, sir. Thank you so much, sir.